Welcome to Health Center. I'm Dr. Monica Sweeney from the School of Public Health here at S.U.N.Y. I am very pleased that you've joined us this morning, and I am pleased to welcome Dr. Michael Augenbaum, who is the director of the Infectious Disease Department, both here at Downstate and at Kings County. Thank you for joining me.
Thanks for inviting me.
You know, after all of these years, I want to talk about HIV in terms of its context, where we are now versus the dark days. And you've been here to see it, most of it.
Yeah, I came here a little more than 25 years ago, and at that time we had a lot of HIV infection in the community. Not that we don't have it now, but we had a lot more in those days. And we had no effective therapy, no real effective therapy. So we tried to mitigate problems, treat people as they got sick, but invariably people would usually get quite sick and oftentimes die. I'm thankful that we don't live in that era anymore. About 20 years ago, we had the introduction of two things which have really revolutionized HIV care. One of those is very effective therapies, combination therapies, and the other thing is means by which to assess the efficacy of therapy. That is, particularly ways to measure whether the therapies are working well or not, so that we can change if necessary. And those two things have basically changed the face of HIV.
Before you get to treating, do you do tests to see that the strain of HIV that the person has is sensitive to the medicines that you are going to put them on?
Yes, it's generally recommended that once we make a diagnosis that we both measure the amount of virus that's in the blood of the individual and also do very specific testing to look at specific susceptibilities of the virus to each of the available antivirus medications, so we can choose wisely. In the old days, I guess when we first got started and we didn't have this, it was a bit of a guessing game, but we don't like to guess about these things.
Well, there wasn't a lot to guess about. When I started treating HIV, there was one medication, essentially. And so you guess, yes, will the patient take it or not?
Right.
The other thing is I'm sure you've seen a lot of opportunistic infections in your day. Are there still people coming in with AIDS when you first see them?
Yeah. Again, in the old days, going back 25 years ago, the hospital had a lot of admissions with people with advanced HIV, which we refer to as AIDS. And these people were oftentimes sick with what are referred to as opportunistic infections. That is to say that their immune systems had become so weak from the effect of the virus that they were unable to fight off the sorts of infections that nobody otherwise would see in health. And our hospitals were full of people like that. And I can remember a time when we had to have dedicated units in the hospital exclusively to the care of such patients. But again, once we introduced these highly effective therapies, those units became superfluous. We didn't need them anymore because people were not being admitted in the same numbers. Getting to the question that you asked, though, do we still see patients like that? They do still come to the hospital occasionally. And generally, these are people who don't know that they have HIV and have reached advanced stages of infection, or those folks who know that they have HIV and have neglected for one reason or another to avail themselves of effective therapies.
If you see someone who is not adherent to their medications, what is the process that you go through to try and get them? Because in this community, medications, not just for HIV, but other medications, have bad reputations. People are distrustful. What do you do to help them get over the hurdle of not taking their medications?
Well, it's hard. I mean, I think we all have to recognize the fact that taking chronically medications for any condition is difficult, and all of us realize that, but there's nothing we can change about that situation. If you take the therapies, you live longer, you live healthier. So we first of all have to try to, of course, counsel the patients about this sort of thing. Establish a good relationship with a patient so at least they feel like they can trust their health care giver. Somebody's giving them a good message. We've also had the opportunity over the many years to improve the therapies themselves. When we first introduced these effective therapies, patients had to take fistfuls of medications, oftentimes.
Remember that sign?
Yes, yes.
With a handful of pills? And now?
Unbelievable. How we assume that people were going to be able to take all those medications, I don't know. And they made people sick, too. They gave a lot of side effects. And the process has been so refined that now we have many regimens that we can avail ourselves of that are one pill once a day. And they have very low side effect profile. They don't interact with a lot of other medications. And you ask people who take care of HIV patients, and they will tell you that in some ways, if you get to that point where you can use these agents, it's easier to treat than things like diabetes or hypertension, except that you must take your medication every day.
Because what people don't know maybe is that one medication, that one pill or caplet has multiple medications in it.
Yes, yes.
And what happens if they stop it?
Well,
Or skip a week because they go on vacation, or run out of pills or something?
we don't cure this virus. The virus, although our goal is to suppress it to levels such that we can't measure it using modern technology and thereby eliminate replication and damage that it can do, the virus is still hidden inside people who are infected. And it's unforgiving. So if we allow ourselves to drop off of medication and for levels of the drug in the system to go so low, the virus will escape and recur again. And the problem is that not only that happens, but that the virus is a very good biochemist. And simply by dint of evolutionary pressures, the viruses that pop out may now be resistant to the drug that we were using before. And so if we just simply introduce the old medication, it may no longer be effective.
I have patients who ask me still, even though I'm not practicing HIV clinical medicine, my viral load is undetectable. Do I have to use condoms?
Good question. I think a lot of the current data that we're beginning to see is about this whole larger issue around treatment as prevention. If we can drive numbers of infected individuals down in the community or get them on therapy, then we can really control this infection. And the question about the risk of transmission, which is what I think you're asking about, is there a risk of transmission if people have undetectable viral loads? And the answer to that question seems to be zero. It seems to be next to zero. That is to say that if an individual has no detectable viral load and they engage in unprotected intercourse, the risk of transmitting virus is vanishingly small. There is an ongoing debate right now whether for these individuals we need to continue to recommend aggressive protective measures for sex. Now that doesn't exclude the possibility of getting other STDs, and I think many of us are concerned that people who have HIV, who have undetectable levels, who understand that their risk is very low, now feel that they can engage in unprotected intercourse. One of the offshoots of this is increasing rates of STDs.
Yes.
Which we certainly don't want to see.
Which we're seeing.
Yes,
as you
we
know.
are.
Why am I telling you? You know, I just want the public to know.
Right. We are seeing rapidly increasing rates of syphilis, gonorrhea, and chlamydia. And these are all bad developments. They're bad diseases in and of themselves, and I also fear that they themselves can enhance HIV transmission. So
you named three. You named syphilis, gonorrhea, and chlamydia. What about herpes?
Herpes,
which
certainly.
Which, of course, if you have it, makes it more likely that you'll get infected with HIV.
Yes, and herpes is tremendously more common than any of those other things that I mentioned.
So people, you're not transmitting HIV, you may transmit something else.
Yes.
So what is it looking like going forward? We have been successful, if people take their medications, in extending the life expectancy. But what does it look like going forward in terms of new ways of taking medications?
I think that in the immediate future, one of the issues that we'll be addressing is ease of use of medication regimens, so that reducing pill burdens to one pill once a day, people would like to actually, you mentioned before how these are combination therapies, 3 drugs in 1 pill. For many individuals, can we simply use 2 medications in 1 pill? So there are ongoing studies looking at this particular issue. Also trying to reconfigure the drugs in those combinations to reduce the potential for side effects. There's no elimination of side effects with any medication, but we can reconfigure drugs to, again, reduce the risk of side effects. There's also some interesting work being done right now using injectable drugs. And it's conceivable that for some patients, this may not be right for all patients, but for some patients in the not too distant future, we can offer them a depot injection once every 2 months, let's say, or even 3 months of medication, and they wouldn't have to take meds for every day as they do now.
Is that in clinical trials already?
Yes, yes.
To 1 injection every 3 months to control your HIV?
Yes.
What about the same kind of technology as for hormonal therapy for contraception, where they can implant it? Anything going on there
You
yet?
know, I don't honestly know that. I mean, I'm sure people are working on that or certainly thinking about that. The injectables for which there are trials that I'm aware of don't use those sorts of technologies, but it's probably around the corner anyway.
You know, smallpox was cured. We need to cure HIV. I think the only way we'll ever do it is by having a vaccine. What's on the scene as far as vaccines concerned?
Yeah, I mean, people continue to work on a vaccine, but I think nature sort of always takes advantage of our lack of knowledge. And things that we thought we could apply using models for other infections, like smallpox, for example, just don't seem to work here. HIV is a wily adversary. It changes rapidly, and it's been thus far hard to identify specific targets on the virus for which you could develop a vaccine that would absolutely control the virus itself or prevent it from taking up residence in somebody. But who knows? I mean, people are working at this regularly, and we learn a little bit every day, and every day we learn a little bit more. So it's conceivable in a year or two that somebody might make a breakthrough in this area.
Well, that's an optimistic note
Why not
on
be
which to end.
optimistic?
Thank you very much for being here, Dr. Augenbraum.
You're welcome.
We'll be right back with more of Health Center. Please don't go away. Welcome back to Health Center. I'm Dr. Monica S.U.N.Y. from the S.U.N.Y. School of Public Health. This is our World AIDS Day program. And with me is Dr. Jeff Birnbaum, who is on the Faculty of Pediatrics here at S.U.N.Y., as well as a faculty in the School of Public Health. Dr. Birnbaum is also the Executive Director of the HEAT program here at S.U.N.Y. Downstate. Welcome, Dr. Birnbaum.
Thank you for having me.
And also with us is Michael Robertson, who's a public health practitioner, advocate, activist, leader within the LGBT community, as well as adjunct professor at the New School University Lang College in New York City. And welcome and thank you for being here.
Thank you, Dr. S.U.N.Y.
Well, we are going to start because I used an initial to start with, which is called HEAT. So tell us what HEAT means.
HEAT is Health and Educational Alternatives for Teens. We've been around since 1992. Our founding goal, not our only goal and mission right now, but our still part of our core mission is fighting the AIDS epidemic, the HIV epidemic in adolescents, young adults. We serve young people ages 13 to 24 years old.
And since I've known you a long time, I know some of the challenges, like your 24-year-olds don't want to leave you, but we'll get back to that. And Mr. Robertson,
Yes.
I hear and read on your bio, which is very long, so I didn't read much of it, that you are from the houseball community.
Yes.
So I want to know what a houseball community means.
So the houseball community is initially what we used to say, or historically, it's an underground LGBT, Black and Latino LGBT community. But particularly the way that it looks today, because it expanded so much, we don't say underground anymore. But it is a Black and Latino LGBT community who has its roots in Harlem, in relationship to Black church during the Harlem Renaissance, when the Black church particularly was trying to rid Harlem of its queerness, and drag balls, black transgender women created a space for competition, but that in many ways became a safe space. I also call it a freedom movement and a black transwomanist theological discourse. And over the years, after World War II, it migrated to other cities that became blacker. And then in 1967, a black trans woman in Crystal LaBeija resisted against racism in the drag ball circuit, and then it morphed from drag ball to house ball. And then in the 70s, she saw the formation of houses. In relationship, I always talk about in a political relationship to Stonewall, here's a community that are creating houses to not only be safe because kids were being ostracized from their own family, but in many ways as a freedom movement, migrating, mobilizing in response to systematics of oppressions. And these balls are spaces where we compete for.
No, just before you get to the ball, let's get back to the house part for a while. Are there actual physical houses where people live, stay, work? What does the house part mean? I know the ball part, I've seen that. What is the house part?
And that's, the way that you formulated that question in response to mine, just to make me think of something that's very different. So you're right. So oftentimes we can clearly understand what the ball part is. But the house part it's abstract, so it's not a concrete house. But it is, and in many ways, no different than black fraternity. So no different than an abstract space that binds people together. Now it is true that there are families. Absolutely. Thank you, Dr. Birnbaum. Families, but it is true that because of a whole bunch of societal ills, that some of the young people have lived with mothers and fathers of houses, but there's no real concrete house. And houses initially were named after famous black trans women who were famous in the drag ball circuit, and then these houses were named, people just created names. And then you began to see in the 80s, particularly in relationship to Ronald Reagan's neoliberal politics, the creation of houses named after fashion designers. So the house of Miyake Mugler, or the house of Chanel, or the house of Prada.
Now, why were they named after designers?
Well, so my historical analysis is partly it's because you think of the 80s and neoliberalism and the greed kind of era. Also, this notion, what I call the politics of respectability, oppressed people looking to be seen as respectable by the oppressors, so naming themselves after white designers or what have you. So,
having heard this history, how did Heat get involved with Houseball?
We were trying to figure that out last night on the phone, how we first started doing that. I had approached Mike and his former executive director at an organization called People of Color in Crisis well over 10 years ago about working together in collaboration to provide HIV testing for young black gay men at his organization, outposting our services at their organization. That's how it started. I didn't know anything about the house ball community until the first ball at Paramount in Times Square. If you remember that particular one.
Yeah.
And I said to my wife, I'm going to work. One night I got there at about 11 o'clock at night and showed up at about 5 o'clock in the morning, and my eyes were opened up to a world I didn't even know existed.
You're still married.
I'm still married, and my wife comes to the balls too, as does my daughter.
You may not remember that I came to a ball.
That's right.
I came to a ball because I wanted to know what went on, and it was eye-opening because people were vying to sit at the head table with you, and you were doing it was based on how many HIV tests they had done the week before or something like that.
What we had done was, in order for particular houses, and I think at some point we should talk about the Kiki houses, which are really the ones that youth participate in more. Kiki houses are more of a youth movement, but sometimes in order for a particular house to get a VIP table, we'll have a campaign. What's interesting, nobody ever sits down at the table. They're all standing up and or standing on the table, but nobody sits at the table. But it's a big thing for each house to get their own VIP table. So we had a campaign the week before the ball to see, houses were competing not just on the runway through the voguing, etc., but they were competing to get their VIP table. So each house ran its own campaign in order to get
To do HIV testing.
They tested with us, but they scheduled their own times. They organized it house by house, and that's how we promoted testing. Part of the challenge with working with young people in the house ball community is being able to fit testing as well as other health services into their space. And we've been talking a lot about how to refocus the discussion about the community.
But you said their space.
Their
space, not meaning a physical space.
Community.
Into
Yes.
their community.
Yes.
Okay. Is it as active and alive as ever, or is it decreasing, or?
Increasing. So partly, you think about, just listening to Dr. Birnbaum's, it's interesting that it again was created in New York City and then it morphed to house ball. And house ball was only in New York until 1986. And then it moved to D.C., migrated to D.C., and then 89 in Philadelphia, and 1990 in Baltimore. And so today, in almost every geographical region in the United States with large numbers of black folk, there's a house ball community. And now we're having this push and pull relationship with Europe. So there are a lot of European houses that are chapters of New York houses. And then two particular cities I think are interesting, which is Paris, France. A young trans person came to New York City, leaving Paris in the late 80s, looking for a black gay community, finds the pier, winds up finding ballroom, becomes a member of the House of Ninja, then goes back to Paris and creates the black gay community by creating the house ball community. I was just in Sao Paulo, Brazil, doing community organizing, and there's an emerging house ball community creating there as well. So
It's very interesting that you should say that about Brazil, and then that they didn't have one until recently, because the first time I was in Brazil, I saw a drag parade many, many, many years ago. And so it's very surprising that they're just getting the concept of house ball translated to there.
Well, partly it's because one of the things we do is we convolute drag performance to house ball.
Okay.
And so there's a history. And the other thing too is and I have to push back on my own self because I'm saying newly emergent only because I saw it for the first time. But reality is that there are folks who've been voguing and looking at us through YouTube for a couple of years now. And when I was just there in Brazil doing some community organizing and doing some lecturing, we had a couple of events that brought them all together.
Now, I know about the HIV testing because I did witness that. What other activities does HEAT and house ball do in terms of health issues?
Well,
even though this is World AIDS Day, we want to know everything that you're doing.
Well, just to finish up the HIV discussion, because the level of stigma is so high, to be a constant presence, maybe I won't use the word space again, but within a particular community, to be a constant presence there, both myself personally as well as the HEAT program, HEAT staff, we give out tons of wonderful swag to people who come to our events. Being a trusted name so that even if people don't test at the events, it can be something else, a health issue. It becomes a trusted place that somebody can come to. Sometimes it's not even a health issue. It's about homelessness. Quite often, it's a mental health issue that needs to be addressed. So
homelessness is a health issue, and I know you know that.
Yes.
And I know you know that. You were just using it narrowly then.
Housing is treatment.
Housing
Yes.
is treatment. Housing
Yes.
is prevention.
Yes.
And
But it's a way to engage the young people that we're trying to serve in a more global fashion and not just about testing and numbers. Yeah, testing and numbers are important because the funding that drives those activities we have to be able to report, but it's not limited to that narrow scope. We're looking at not just a whole person but a whole community and trying to address huge disparities faced by the community.
I'm just going to ask this. We may not have time to get into it in detail, but a colleague and friend in the Bronx has been following about 2 100 trans people for a while. And when he did a report out, when he was writing for funding to continue to be able to follow them closely, the group that he had been following for a couple of years, only one seroconversion happened in this couple of 100 trans people. Do you have any suggestion of data or anything that suggests that by being associated with heat, and you associated with the ball, that it is a way of keeping people engaged, safe, not getting infected, anything like that?
I mean, I think a couple things. One is, one of the things, I've been a colleague and collaborated with Dr. Birnbaum for a while. And so one of the things that in many ways he's alluding to is shifting this narrative. So one of the things that happened last weekend was his Deputy Executive Director, Jennifer Lee, had wrote a grant to do a part of a national convening that we have been doing over the 5 years. And it was called House Lives Matter. And the intent was to shift sort of the narrative of the houseball community from a pathology of illness to a resiliency of wellness, but saying that health is a human right. And in that the way that we approach the wholeness is intersectional. So we did stuff on mass incarceration and Black Lives Matter, but more importantly, we did a town hall meeting at Union Theological Seminary. And I bring that up because I went there, I'm an adjunct professor there, and it is my assertion that theology, this notion of abomination, has a direct impact on health and wellness of Black LGBT folk. And so in that, because I do work with Dr. Birnbaum, some of the groups that we do with HEAT, we do actually at the seminary. So we do 3MV, Many Voices,
And
actually at the seminary, Vogue Theory as well, actually at the seminary, to have this not only subliminal conversation, but this intent and concerted message around shifting this narrative.
I think that's a really wonderful place to leave this conversation right this minute, because we're out of time. But I really enjoyed the conversation, and I'm sorry I didn't get a chance to talk about the CDC program. But out of your experience came that CDC program. I thank you very much for being here, both of you, Dr. Birnbaum and Mr. Robertson.
Thank you so much,
Thank
Dr.
you.
Sweeney.
That's our program for now. We thank you for joining us. Please join us next time. Thank you.